Hi everyone, this is an overview for adult Warfarin Protocol. A lot of hospitals and also a lot of ambulatory care clinic, especially those anticoagulation clinic, will have some sort of protocols or at least a guide to kind of help the pharmacist in managing patients on warfarin. And again, this is the reasons being is because warfarin is a blood thinning agent, it's a high-risk medication like the heparin. And it is very tricky in terms of adjusting the dose. So a lot of times I will have sort of like a range in terms of like how much you can adjust the dose, and how much you can adjust it based on the INR. So it's very helpful to have those guides. But again, guide is just a starting point. Pharmacists always have to use their clinical judgment to individualize how you will manage the warfarin for each single patient that you see. And again, most of the protocols will have initiation process steps in terms of how the physicians can order the warfarin and have the pharmacist to follow and monitor the warfarin. A lot of times, if it's warfarin per pharmacy protocol, then that means that the physicians give us the responsibilities to monitor, to follow, to dose daily. It's kind of like more like us assisting them, because that's kind of like our expertise to manage medication, right? So a lot of times the whole responsibilities of the warfarin dosing fall under the pharmacy in that sense. So there's a lot of responsibilities there. And then once they order warfarin per pharmacy, then the pharmacist will start working on the patients, right? They receive the order, they'll review the patients, review the appropriateness, assess if the patients can get a dose, if they, is it the first time that they're getting the warfarin, or did they have warfarin from, at home, and then they're just continuing while they're being admitted in the hospital. So a lot of things are going on as you start somebody on warfarin or receive somebody on warfarin in the hospital. And then in this protocol, I break it down to those who are, for patients being initiated the first time, for indication, for example. And then the next section is for those patients who maybe got admitted to the hospital and then they have been receiving warfarin at home, right? And they're just continuing it or resuming the warfarin in the hospital. And this section right here, the adjustment and the guides can also be used for those patients who are being followed in the ambulatory care setting, like in the anticoagulation clinic. So this can, this parameters and adjustment rate can be used in the outpatient setting, not just inpatient. And so let's kind of go through the first section first, where we're going to be talking about how to initiate and dose warfarin for those patients who just got started with warfarin. Usually in day one, we could have started with like a higher dose, right? Typically it's between, I would say most commonly I've seen 5 to 10, and it will be based on multiple different factors. So those who are going to be at high risk for bleeding, we're going to be more conservative, right? Lower dose. But those who are young, healthy, no comorbidities, we don't worry about bleeding risk, then we can probably, do a 10 milligrams. Other factors to consider about, like what's their baseline INR. Those who are not on warfarin, who doesn't have any coagulation disorders, their INR are going to be normal, right? You typically around 1 or even lower sometimes. So those we can probably, consider higher dose. And then those who are overweight, obese, they might need a higher dose, right? So that they can get more exposure from the warfarins because of their weight and distribution. What about their medications, right? Kind of take a look at their medication list. Are there anything that might interact? Are there anything, and how is the interaction to happen, right? Is it going to increase your warfarin or dosing or exposure in the blood? Is it going to decrease, for those that are inducers of the CYP450 enzyme? Or is it, like it might not interfere with warfarin metabolism, but it can, contribute to increasing the risk for bleeding, for example, like NSAID, right? So those are kind of like the thing that you need to think about while starting somebody on warfarin. How about PO status or diet, right? You all know that warfarin can interact with vitamin K containing diet. So if they're not eating well, or like if they eat too much leafy green, then it might affect the INR, right? So kind of like consider all those stuff. What about CBC? Are they having any active bleeding? Is hemoglobin is like, lower or like borderline lower? So we might be more cautious in terms of, dosing them at maybe more conservatively. How about comorbidities, renal or liver impairment? There is always excretion and metabolism done in those settings. For the warfarin. So if they have impairments on those, then they're not going to be clearing it as well, right? Or metabolize as well. So those are some things to consider as you start the warfarin. How about like, history of coagulation disorders or bleeding? We might need to be more conservative in that part, right? If they have high risk for bleeding, or if they have increased risk for coagulation disorders, right? And also, what about major surgery, right? So those are kind of like the thing, because major surgery can, one, to increase your risk for DVT, but also, like if the surgery wasn't done appropriately, there's increases for bleeding. So a lot of factors to consider as you initiate the warfarin and to determine the doses. And you can see, because there's so much things going on with dosing the warfarin, it's good to have a guide, right? But again, a guide is just a guide, it's a starting point. You always need to look at your patients to see, like what's more appropriate. You might follow the guide, if you think it's appropriate, but sometimes, like the guide might not fit what your patients have in terms of their, clinical factors. So again, always, always, always have your clinical judgment while dosing the warfarin. So those are kind of like, the starting dose, day one, and then if it's in the inpatient setting, daily doses might be different. So today you might give this patient 10 milligrams. Tomorrow, depending on the INR, if it doesn't budge, if it's still the same, like the INR from yesterday, you might still kind of consider giving them like the same dose or like, a slightly lower dose, and then as you go through the day, over time, daily life, your dose might be lower and lower. And then again, it's all based on the INR. And then you need to predict or anticipate when the INR might start budging up. Because you can remember, right? The warfarin doesn't take effect immediately. It takes days or even a week before it will budge your INR or increase your INR. So those are kind of like things that you need to think about. At least like 3 days before you might see an effect, and to take the full effect, to have the full, it might take like about within 1 to 2 weeks for the full effect to happen and to have the warfarin stabilize in your body at steady state. So a lot of times this is why the guide will be helpful to kind of tell you, okay, if we give like maybe 10 milligrams on day one, right? What about day two? So if the INR doesn't budge, it was 1 yesterday, maybe it's like 1.1 today, it hasn't budged much, right? Then you can repeat the initial dosing, maybe give another 10 milligrams today, right? And then the second day, the third day, day 3, and then you monitor your INR again to see like what's the INR at that time. If it's still around this range, you can repeat another 10 milligrams, right? And then you sort of follow the guides from that point on. Again, you have to use clinical judgment because this is day 2 to 4, right? If, like I mentioned, INR may take like 3 to 5 days to take effect before you see the changes in INR. So if you think about it, if with somebody, who might, who might be less sensitive, but then have like problem with like metabolism or excretion, maybe I wouldn't repeat the initial dosing, especially if it's like 10 milligrams, because it's very, very high dose, 10 milligrams daily, right? So those are kind of like some little details, specific patient factors that you will need to kind of take a look at to determine if this guide right here, can be followed for your specific patient. And then you kind of like go through day 5 and so on with the new algorithm once you get there. And different goals will have different algorithm, just because, like for example, this table right here is for goal INR of 2 to 3, for most of the indications. And then this one is for 2.5 to 3.5 for a specific indication, right? In this case, it's probably going to be more aggressive, right? Just because you are targeting a higher goal of INR. So you can be a little bit more aggressive in terms of your dosing and the threshold as well. And in patient setting, you will monitor the INR daily. And that's kind of like how it is when somebody is on INR and they're on inpatient setting. Now, let's kind of go over how it will go if the patients receive, is taking INR outpatients, and then they got admitted, and then we need to resume the warfarin, right, in the inpatient setting. What do you do? So a lot of times, if they're at goal, like depending on what their goals are, 2 to 3 or 2.5 to 3.5, then definitely you can, keep continuing the dose that they are getting at home, right? And you have to get a little bit of history from the patients too, to make sure you are really getting the right history and overview of how the patient is taking at home. And you need to know like how much they're taking daily, because sometimes it might not be the same dose daily. They might be on, like, for example, 5 milligrams on Monday, Wednesday, Friday, and the rest of the week they're taking 2.5 or something like that, right? So it needs to be very clear in terms of how they are taking the warfarin at home, what dose daily, and have they been compliant with the warfarin, right? And then think about like how would their, while they're in the hospital, how would their lifestyle change, from what they were on at home, right? Because their diet might change, right? Maybe, for example, they have been eating a lot of greens consistently, right? Maybe in the hospital, they're not given as much greens that they're taking at home. So that will change your INR, right? Like, because of the vitamin K content of the diet decrease in that sense. And anticipate what kind of INR change you might get, from decreasing vitamin K intake from being admitted to the hospital. So those are kind of like sort of the things that we need to consider while we are continuing their warfarin in the hospital setting. What kind of lifestyle might change? Or maybe, another examples that I've seen before, maybe they're taking alcohol at home. Alcohol interact with warfarin, right? And then once they're in the hospital, obviously you're not going to be giving them alcohol, so it might change the INR as well, right? So those are a lot of things that needs to be done. Again, always review their medication list, see if there's any interacting medication, right? Especially warfarin has a lot of drug interaction. And this is kind of like the algorithm or adjustment guide in terms of how you can adjust the medication if they're not therapeutic, right? Maybe like, if they are supratherapeutic, then definitely you need to decrease the dose, right? And depending on how much supratherapeutic they are, the range of the dose decrease can be between 5 to like even 20% sometimes. And if they're really, really high, above 5, usually you might hold the dose for certain days. And keep in mind, the dose adjustment is a bi-weekly dose, not daily dose adjustment. And because, like I mentioned earlier, right, warfarin doesn't take the dose that you take today, it might not, the effect in your body might not be seen until 3, 5, or even a week later. So that's why we can't really just dose your warfarin daily. We have to do it weekly when we know, like, like that, when it's going to be closer to steady state in the body. So the way you do it is that you total up the total weekly dose that the patient is taking. For example, if they're taking 5 milligrams daily, just to be simple, then it means like they're taking like 35 milligrams of warfarin weekly, right, in total. So the way you adjust it, then you will take like, percentage of that amount of that total weekly dose of 35 instead of 5 milligrams, if that makes sense. So for example, if we do like 10% decrease, then it will be 35 minus 3.5 milligrams, right? So it will get you to 31.5 milligrams. And then from that 31.5 milligrams, you have to divide it into daily doses. You divide it by 7. You might not get the exact amount, of like 31.5 divided by 7. And then you can kind of sort of play with your tablet size and also the dosing. And again, like the dosing doesn't need to be similar every day, right? So you can play with that dosing in that way. Play with different tablet size, different dosing every day, but make sure if you don't are not going to discharge patient with different doses every day, make sure it makes sense, right? So don't do like 2.5 milligrams on Monday, 3 milligrams on Tuesday, 5 milligrams on like Wednesday, right? Because it's going to be super, super confusing for a patient. You're going to increase harm, you're going to harm risk, you're going to increase like error on the patient's part if once they got discharged and they have to take like different doses every day, right? Make it so that it's, even though the dose is not the same every day, make it at least like somehow it's easy, make it easier for the patients in some way as well. So a lot of times what we, typically do, we would prescribe them like one strength of the warfarin. A lot of times it might be like 5 milligrams, like that's the most common one I see. And then if you don't want the patient to take like 35 milligrams, for example, right? Maybe let's say we want them to have 31.5. So what you can do is, let's see here. So we want to decrease it by 3.5. So what you can do, and again, like it can be a range, right? It might not be exactly 31.5. Maybe it can range from like 5 to 10%, right? So it can be like from like 31.5 to, let's see, what's 0.9, so to like 33.25, right? So those are the range of like the dose decrease that you can go into. So 31.5 to 33.25. So in the middle, there's like 32.5, right? So what you can do is decreasing the weekly dose by 2.5 milligrams. So instead of, dividing 32.5, like 32.5 divided by 7, that gives you like about 4.6 milligrams. That's not a convenient dose, right? So you can still, prescribe the patients the instruction with like maybe 5 milligrams, and then just have them take 5 milligrams 6 days out of the week, and then just decrease one of the day by 2.5 milligrams, and then you instruct patients to do, okay, take 5 milligrams daily for 6 days of the week, maybe Monday to Saturday, and then on Sunday you take only half tablet of the 5 milligrams, so 2.5 milligrams, and they give you about 32.5 milligrams of total weekly dose. And so that's kind of like one example that you can do for dosing the warfarin. Hopefully that makes sense. Again, dosing warfarin, adjusting warfarin can be a little bit tricky, and it takes a lot of practice. So I would encourage you guys to do a lot of practices, like consider about different scenarios, and from case-based cases to like, we will practice a lot, with warfarin adjusting and everything else, so that you are more comfortable once you go into API and also as a practicing pharmacist.